Hello, I'm Selena Galilea Paginto, presenting a case study on the syndrome of infant of diabetic mother for my NNP1 Concepts and Practicum GNRS 5631 Spring of 2021 at the University of Texas Medical Branch. Our objectives for this presentation are to understand the pathophysiology relating to the syndrome of infant of a diabetic mother, enumerate the complications affecting the neonate, list the potential problems of the infant at risk and the signs and symptoms, recognize common congenital anomalies and their management with a focus on VSD and CHF, identify the 6 steps of integrated evaluation of neonatal hemodynamics, recognize equipments associated with hemodynamic monitoring, and acknowledge family emotional dynamics as a base for family-centered care support. Our case study. The neonatal resuscitation team was called to the delivery of a 40-week female infant by rapid response code. Infant was dusky and had a weak cry as she was dried and stimulated. PPV was done with 50% oxygen for more than 30 seconds, where she started crying vigorously and then continued to pink up with acrocyanosis on the upper and lower extremities. Her breathing improved after 30 seconds more of PPV. Afterwards, she was suctioned using a DeLay, removing 12 ml of meconium-tinged gastric secretion. Due to irregular respirations with slight subcostal retractions, oxygenation was given via CPAP, with decreased O2 at 30%. Because her O2 sat were 89 and 92, then at 5 minutes of life, O2 was decreased to 21%. She weighed almost 4,000 grams, had an APGAR score of 8 and 9. Her left arm seems to have less movement, but she is crying, pink, with good respiratory effort, so she was transitioned at the newborn nursery. On report, we learned that this is mom's 9th pregnancy. So she had 4 term infants, 4 preemies, 1 miscarriage, a total of living 8 children. She has been ruptured the day before for almost 13 hours. She had prenatal care in Mexico, was diagnosed to have gestational diabetes, diet controlled, but she just came in the morning and received 1 dose of antibiotics. Her GBS status was unknown, but the rest of her lab works were negative. A few hours later, she was transferred to the newborn intensive care due to an initial POC glucose of 17, which came to 35 milligrams after feeding her 20 ml of Similac Advance, but with difficulty. An IV bolus of Ditan water at 2 ml per kilo was given times 1. An IBF of Ditan water was started at 80 ml per kilo per day. She was also started on feedings per gastric tube because her follow-up glucose was only 40. Good thing the succeeding blood sugar levels were acceptable, but she was continuously monitored for other complications associated with the disease. In the syndrome of infant of a diabetic mother, the neonates are affected by complications caused by maternal gestational diabetes. The condition arises from the elevated maternal blood sugar that affects the development of the fetus in utero, causing diabetic embryopathy. The result is an increased blood sugar level in the fetus, triggering an increased insulin production, faster weight gain, and more complications known as diabetic fetopathy. According to Blackburn, this phenomenon is due to the excessive transfer of nutrients to the placenta that causes hyperplasia of the pancreas, causing increased production of insulin, growth factors IGF-1 and leptin, amplifying lipogenesis, glycogen and protein synthesis with intensified glucose, protein, fatty acid transfer, and increased triglyceride storage in the fetus. There is also rapid organogenesis, but there are also associated malformations accompanying this syndrome. With this increased hypermetabolic state, it is believed that the malformations arise due to the following reasons. The formation of free oxygen radicals in the mitochondria, the inhibition of prostacyclin formation resulting in an excess of thromboxane A2, which is a potent vasoconstrictor, decreasing perfusion at the cellular level. There's also altered levels of arachidonic acid and myoinositol. There's lipid peroxidation, increased somatomedin inhibitors, accumulation of sorbitol and trace metals, and hyperglycemia-induced apoptosis with exaggerated programmed cell death. In summary, the resulting hyperglycemia inducing increased insulin production alters metabolism that has a teratogenic effect on the fetus. The neonate could present as an overgrown premature infant with or without malformation or maldevelopment. So what are the effects on the neonate? Infants of mothers with diabetes are at increased risk for the following. Delivery complications due to macrosomia, which increases the risk of birth injury, such as brachial plexus injury or fracture, perineal asphyxia, prematurity, cardiac complications, such as transposition of the great vessels, aortic stenosis, ventricular septal defect, cardiomyopathy, due to altered or enhanced organogenesis, explained as diabetic embryopathy and pitopathy. Respiratory complications such as RDS, meconium aspiration, TTN, PPHN, due to delayed development of the lung tissue and decreased surfactant due to elevated insulin levels. Metabolic complications, including hyperinsulinemia, inducing the hypoglycemia, hypocalcemia due to low maternal parathyroid hormone levels and sudden drop within 24 to 72 hours of birth, hypomagnesemia due to low maternal levels, and also increased maternal urinary loss secondary to her diabetes. Hematologic complications include polycythemia. This is caused by the fetal hypermetabolic state requiring increased oxygen that induces increased erythropoietin production. And also it causes hyperviscosity. The low iron stores are due to the increased utilization but low reserves. Hyperbilirubinemia was due to the consequential increased RBC production and destruction. And there are congenital anomalies, such as caudal regression syndrome, spina bifida, or small left colon syndrome. In retrospect, our patient presented with a long list of problems and risks. Let us examine them one by one. Born almost 4,000 grams, our infant weighed 8 pounds, 12.5 ounces. Her gestational age assessment revealed that she was 37 weeks and below instead of 40. She measured above the 90th percentile of the Fenton growth chart. And as she came out, the delivery nurse mentioned shoulder dystocia where it showed decreased movement on her left arm. So one by one, you can check the list: prematurity, large for gestation, preterm labor, shoulder dystocia. The color of the fluid on her head was greenish, and her presenting part, which is the forehead, also looked bruised, while her lips manifested with circumoral cyanosis. She let out a weak cry with irregular breaths, was given PPV. She recovered her O2 sats from 89 to 92, 92 to 96, slowly went up, but she was still acrocyanotic. She was transitioned to the newborn nursery, then transferred to newborn ICU because of the low blood sugar levels. She also started showing signs of respiratory distress. On our routine admission labs, we included a blood culture and a CBC, and we want to monitor her for infection because she's at risk. Her mom ruptured 13 hours before she delivered, and so we need to observe her and evaluate her for sepsis. Her blood sugar levels started going up after the bolus, the D10 water, and the feedings. On the second day, we gave her calcium gluconate because her calcium level was 6.7. Her hematocrit was also elevated, and she started showing signs of hyperbilirubinemia. Her total serum bili was 9.1. She was placed under double phototherapy. Bilirubin levels were checked daily. We also requested a cardiac consult due to the presence of a murmur, which showed a small PDA, a small PFO, a muscular VSD, no cardiac hypertrophy, no vegetation based on echocardiogram. Hemodynamically, she was stable, but we closely monitored her for PPHN. Her chest X-ray showed mild RDS. Thankfully, there was no sign of meconium aspiration. Her respiratory condition remained guarded, but we kept her on a high flow at 21% and 4 liters per minute. Her left shoulder continued showing improvement and full range of motion. There was no fracture, no other injuries noted. But her bowels became distended. So we had to monitor her closely because it increased 2 cm from the previous measurement. She also had emesis containing partially digested milk. Abdominal X-ray showed gaseous distension, so she was placed on NPO. Supportive treatments were provided. Her respiratory condition was guarded, so the O2 flow was decreased to 2 liters per minute. Upon reassessment the next day, her blood culture came back negative, her abdominal measurement decreased by 1 cm, and she has managed to pass out stools ×2. She started tolerating her feeds, and then we weaned her off from her intravenous fluid, and then later her O2 was discontinued. After a few days, she was discharged with follow-up appointments with her pediatrician and cardiologist. There were no congenital anomalies seen on our newborn. Added to this presentation are the possible complications, with particular attention to ventricular septal defect, because we sent the baby home with a cardiology follow-up. On a small VSD, the follow-up is done at the first month of life, 6, 12 months, and 3 years, if they are gaining weight and no tachypnea, and no other complications such as infective endocarditis, aortic regurgitation, right or left ventricle outflow tract obstruction, and shunting from the left ventricle to the right atrium. Muscular VSD close by the 6th month of age. Meanwhile, moderate to large VSD infants usually become symptomatic within the first month of life as pulmonary vascular resistance declines. So a clinic visit is done within 1 week, and then they're followed up after the 3rd to 4th week of life. They are monitored for tachypnea, increased work of breathing, poor weight gain, or failure to thrive, and diaphoresis, particularly with feeding. This is an important concept of what to teach the parents when the babies go home. Ventricular septal defect can be classified using their geographic location. A membranous VSD, which is the common site for clinically significant VSD, lies just beneath the aortic valve and behind the septal leaflet of the tricuspid valve. A muscular VSD located within the trabecular septum have entirely muscular borders. This is the one that closes at 6 months of life. Malaligned VSD are due to misaligned conal septum, while subpulmonic VSD are located immediately beneath the valves of both arterial trunks. AV canals or inlet occur posterior and superior between the annulus of the tricuspid valve and the attachments of the tricuspid valve. Medical and surgical intervention is for symptomatic VSD based on the severity of their congestive heart failure. Mild CHF is managed with Lasix 1 mg per kilogram BID to TID and then closure before the first year of life if VSD hasn't closed. Moderate CHF is managed using Lasix 2 mg per kilo. BID or TID plus spironolactone 1 mg once a day or twice a day, and then closure intervention. CHF that is severe, which is marked by severe respiratory distress, sweating at rest, and failure to thrive, require surgical intervention by 3 months of age. Those are the things we want to teach the parents to monitor for respiratory distress, sweating at rest, failure to thrive. Supportive measures to stabilize the infant's condition include IV diuretic therapy, OG feeds, because we have to make sure the baby's not going to get tired and that the baby will grow, using 150 kilocalories per kilogram per day. We want to alleviate temperature stress. We want to make sure that their myocardial oxygen demand is less and O2 consumption is less. Also, caloric or metabolic consumption is less so that they will grow. Antibiotic therapy, if bacterial pneumonia is suspected, is also used after a blood and tracheal culture is done. We also provide red blood cell transfusion for clinically significant anemia. We also administer inotropic agents if warranted to prevent hypotension and hypovolemia. Of course, we want to make sure all our organs are well perfused and they are functioning well, and we are preventing organ dysfunction. So, hemodynamic monitoring is very significant for those instances. We also provide supplemental oxygen because we want to decrease pulmonary vascular resistance. We know very well that oxygen is a vasodilator. We want to prevent left to right shunt, and we want to prevent, or we don't want the failure of the heart to exacerbate. As I have mentioned, preventing hypotension and hypovolemia is part of the many goals of hemodynamic monitoring for patients with severe congestive heart failure because we want to prevent multi-organ dysfunction. We can utilize a very systematic approach known as the Integrated Evaluation of Neonatal Hemodynamics, or IENH for short. This is written by El Sayed and Fraser. It has the components of assessing cardiovascular hemodynamics, respiratory physiology, oxygen carrying capacity of the blood, and autoregulation, all of which interact to maintain tissue oxygenation and ensure normal organ function. The steps included in this IENH are evaluation of cardiovascular function using echocardiogram, evaluation of tissue oxygen delivery and consumption, evaluation of respiratory physiology, monitoring of autoregulation integrity in the neonate, evaluation of end organ performance, and writing a full IENH report. And we will talk about it in the succeeding slides. Step 1 of the IENH is evaluation of cardiovascular function using echocardiography. Using targeted neonatal echocardiography, or TNE, this assessment goes beyond structural monitoring because it assesses the cardiovascular function in relation to shunts and internal blood flow. The flow dynamics clearly shows if there's going to be a PPHN or if the flow will affect perfusion to other organs. But this is done by a trained clinician under the American Society of Echocardiography guidelines. Step 2 is evaluation of tissue oxygen delivery and consumption. This will help us determine what could cause respiratory hypoxemic failure. One of the things that we use in the unit is a pulse oximeter because it tells us the oxygen saturation on the hemoglobin of the neonate. We can also evaluate partial pressure of oxygen, plotting the result on the oxygen dissociation curve for both arterial and mixed venous blood gases. Something new is the regional tissue oxygenation index. Although it has been used since 1985, this has been gaining popularity and its function has been widely used in monitoring cerebral perfusion or renal perfusion in babies with circulatory instability. It also measures fractional oxygen concentration using near-infrared spectrometry. NIRS, or near-infrared spectrometry, is similar to the pulse oximeter. It reads the regional oxygen saturation, or the RSO2. It is a non-invasive tool that measures oxygenated and deoxygenated hemoglobin and indicates the level of saturation within that part of the brain or the intestines or the kidney area. So uses are on patients with HIE, IVH, PVL, on ECMO patients, and on patients with CHF. It is also used uh, during PAC RBC transfusion, as it has shown increase in the regional saturation on the splanchnic bed of the intestine. It also is used on neck and PDA because it can monitor the blood flow in those areas. And on kidney, one of the uses is post-surgical. Step 3 is evaluation of respiratory physiology. You know this very well. One of them is measurement of our blood gases and also our X-rays. On the monitors of our ventilator, you can see the flow volume curves. It shows there if there's an obstructive or a restrictive component that needs to be addressed when taking care of our babies on the ventilator. The alveolar arterial gradient, we don't use this calculation, but I know that the oxygen index is very familiar and we use it in the unit. Step 4, monitoring of autoregulation integrity in the neonate. So autoregulation is the innate capacity to sustain circulating volume under any circumstance to perfuse an organ. So this is more like our homeostasis to balance everything at the cellular level. One example is monitoring of the mean blood pressure simultaneously with the TOI using the NIRS. For example, in a neonate with septic shock, the NIRS may show that the brain oxygenation is compromised when the mean blood pressure drops below 35, whereas above 35, the delivery of oxygen to the brain is maintained. Thus, this directs the clinician to use inotropes to maintain blood pressures of greater than 35 millimeters of mercury. Another component of autoregulation are the biochemical markers. Using serum cortisol levels or adrenocorticotropic hormone stimulation test, this will help in diagnosing shock unresponsive to treatment, and it may indicate other conditions such as adrenal crisis, especially those with a low cortisol level. Going back to monitoring the tissue oxygenation index using near-infrared spectrometry. NIRS is suggested to monitor tissue oxygenation that can reflect the balance between oxygen supply and demand of the organ monitored, such as the brain, the kidney, or the splanchnic bed. Step 5 is evaluation of end organ performance. And we do this a lot at the bedside. So how do we monitor renal end organ performance? We do it by monitoring the urine output and serum markers, such as the creatinine and serum electrolytes. We also monitor the fractional excretion of sodium because low output with increased creatinine suggests compromise, especially if the fractional excretion of sodium is increased. On the brain, we monitor minute details such as irritability or change in sensorium in the neonate. We monitor autonomic instability such as heart rate variability, temperature instability. We monitor the reflexes if there's absence of primitive reflexes, the suck, the swallow, the palmar grasp, the Babinski, the rooting. We monitor that. And we try to check if the baby has seizures. With that, of course, we do extensive diagnostics like EEG and neuroimaging. With regards to the heart, we monitor heart rate variability. Is there too much Brady and DSAT on this baby? Is the baby having tachycardia? Well, on some institution, they use the HERO for monitoring heart rate variability while we use our monitor at the bedside. Cardiac enzymes are also used, such as troponin, which becomes elevated when circulation to either organ is compromised. We also check the BNP because the BNP is released from increased volume from overstretching of the muscular wall due to increased pressure with cardiac failure. If there is such cellular damage that we are suspecting an ECG should be done. Because of course, if there's damage, there's going to be wide QRS and there could be heart block and all that. Additional techniques for non-invasive cardiac output monitoring is the impedance electrical cardiometry, which is not available in most NICUs. Or we can use non-invasive blood pressure monitoring like we do, and evaluation of the heart rate variability, like I told you, which is the HERO. The HERO, according to their website, they mentioned that it identifies subtle irregularities in the heart rate variability that occur hours and days prior to the patient deterioration and provides an early warning of patient distress, including sepsis, neck, UTI, meningitis, respiratory decompensation, brain pathology, and death. So, continuation of step 5, monitoring liver enzymes such as ALT, AST, and GGT. And also on adrenal function, evaluation in sick infants unresponsive to cardiovascular or oxygen support is very helpful, especially when they're not responding, because sometimes it could be adrenal crisis. Step 6 is writing a full IENH report. This contains the final impression and clearly formulated recommendations for the management of the hemodynamic compromised infant. Although this comprehensive guideline is a combative tool for the bedside clinician, it is also a useful tool for the primary care nurse because it will enable her to anticipate and utilize this tool as part of her critical thinking process. And of course, the IENH is utilized to prevent organ damage as we anticipate the changes in all this system as a part of all our monitoring parameters we are currently using at the bedside. As I have mentioned before, there were no congenital anomalies seen on a newborn. But I want to add this list because these congenital anomalies have a certain percentage of occurring and presenting on one of our patients. Now, as we learn about those congenital anomalies brought about by maternal gestational diabetes, I want to turn your attention towards the family. So, since we have seen the baby, we have filled the nurse with knowledge to help her at the bedside. Now let's turn towards that family and let's put ourselves in their shoes. Look into the situation through their eyes. Like this mom, on her 19-week obstetrical ultrasound at her local hospital, this soon-to-be mom learned that her baby had a ventricular septal defect, a hole in the wall connecting the two lower chambers of his heart. After hearing the news, she felt it was like being hit by a bus. Another mom mentioned, "My baby had prolonged admission in the neonatal unit, and I believe some of her problems were related to my diabetes. I was very worried when she was 2 days old, when doctors informed me that she has bowel obstruction and possibly might need to be transferred to a surgical unit. However, doctors suspected this rare association with diabetes, where the tail end of the bowel is not well formed in the baby, and this was picked up on X-ray. She soon passed a horrible-looking poo, which looked like her bowels had come out. But after that, her vomiting settled and she started tolerating feeds. I think it is important to consider this complication early on in this setting so that unnecessary transfers could be avoided. So, after reading this comment made by a parent, it gave me a wide perspective on the emotional dynamics they are experiencing, and more in acknowledging their anxiety, worry, fear, or guilt and sadness. Adding to the empathy, we can be more supportive through the involvement of the interdisciplinary team, even psychological counseling if needed. Lastly, we should not forget that the fathers grieve too, and they can also undergo postpartum depression. So we have to be vigilant and be more aware of the emotional dynamics of each family component. Regarding caudal regression syndrome, this baby had decreased limb growth, and on X-ray, there was no sacrum. So, pediatricians, neurosurgeons, neurologists, orthopedic surgeons, cardiologists, kidney specialists, nephrologists, and other healthcare professionals may need to systematically and comprehensively plan this child's treatment involving the entire family, because the treatment depends on the deficiencies or malformation, but the goal is to facilitate the family's adaptation to all these treatments and to support psychological needs with the evolving demands of the neonate. So, the long-term outcomes. Data suggest that prenatal exposure to hyperglycemia increases the risk for postnatal metabolic complications like diabetes or increased body mass index and impaired glucose metabolism. It may also negatively impact neurodevelopmental outcome. Studies have shown that affected kids score less on cognitive tests with other neonatal comorbidities and maternal complications. After our neonates or the infant graduates for our newborn intensive care, we will never see the impact that the syndrome of being an infant of a diabetic mom will bring on the entire family. But we can continue to arm ourselves with the neuroprotective measures to guard them and limit the comorbidities they are at risk for. So we now come to our conclusion. Understanding the factors affecting the neonate and the potential problems due to maternal gestational diabetes, we can use this knowledge to prevent further complications. As we recognize common congenital anomalies in their management, we can anticipate appropriate management. We can utilize the 6 steps of integrated evaluation of neonatal hemodynamics, or IENH, irregardless of the latest equipments for hemodynamic monitoring. And we can provide family-centered care as we recognize family emotional dynamics. Thank you all for listening to this presentation.